Hello, I'm Dr. Jung Young-eun. This is the case discussion to discuss clinical difficulties. We have invited three clinical masters, Dr. Kim Kyung-won, Dr. Son Young-hee. Hello. And we have invited Dr. Park Jong-hyun to this case discussion. This is your first time to this discussion. What is your impression? This is a favorite program among dentists. It is my honor to be here. As a prosthodontist, Dr. Kim Ki-sung gave you very good advices. I will try my best to be as good as him to give enjoyment on top of it. Thank you. Before we go into the exciting discussion, for the dental TV viewers, on the right-hand side of the video player, there is a real-time chatting window for you to post questions to us and share comments regarding the topics. Thank you. Today's guest, the patient is a 56-year-old male. He wants an implant at number 37. It is too close to the inferior alveolar nerve. Available bone is about 8.1 millimeters. If an implant is placed 1 millimeter below the bone, even though I use a 7 millimeter short implant, I'm concerned about the damage to the inferior alveolar nerve. How can I place the implant safely here? And the dentist sent us these CT images. 8 millimeters is the measurement. If you consider the resorbed buccal bone, the bone height would be less than that. Once a nerve is damaged, it's hard to recover it. Therefore, we need to be careful not to touch the inferior alveolar nerve in placing an implant. Dr. Park Jong-hyun, what do you think? I majored in prosthodontics up to 3 or 4 years ago. When I see this patient, I would send them to a university hospital. So doctors like Kim Kyung-won would treat it. After that, I would do the prosthesis. But since I encountered 485, I began to treat this patient. I cannot say to the patient that you have enough bone, but I can say this is something I can do. I cannot say this is my own know-how, but based on my experience, I want to say this. The length measured on CT is shorter than actual length. The 8 millimeters on CT image means longer length in actuality. A manufacturer of a CT machine is not giving you the reading longer than the actual, which would create much bigger problem than the other way around. Considering the angle, I believe the patient has more than 9 millimeters of available bone. If it is 8 millimeters according to the CBCT measurement, you will find after the placement the distance to the nerve is long enough. Honestly, location number 7, it is hard to drill there and the mouth opening is limited. So this is not an easy case, but I don't think it's a really difficult case personally. Thank you. In this patient, short implant might be a choice, I believe. It looks very difficult. Lingually, it's okay. If you look at the extraction socket, the bone doesn't look very good. Short implants or digital guide can be used in that place. I have prepared some slides regarding inferior alveolar nerve, a very difficult case. This patient came to us when I was with the Chungbuk University Hospital. Several years ago, number 37 implant is invading the nerve. When the patient came to me, it was 2 years after prosthesis was delivered, and the patient complained about the paresthesia. I think the surgeon who did this didn't understand the panorama quite well. I think he interpreted the inferior border of the inferior alveolar nerve as the upper border. The dentist scolded the patient, insisting that he didn't touch the nerve. And the patient is complaining about the paresthesia. I don't think the removal of the implant would solve the problem, so that was a very difficult case. This case, a dentist in Cheongju did a surgery. It is not clearly visible here. 2 implants were placed in the lower posterior region in the soft bone, so the dentist pushed them down and they sank down, causing paresthesia, so I removed them. In this case, the patient was referred to me. During surgery, the dentist felt something wrong, so like this, the nerve was severed completely. Among the 3 cases, the middle one, we could reduce the damage even with some sequela, but number 1 and 3 cases, no recovery could be made. Therefore, we need to avoid the inferior alveolar nerve by all means. We have very good machines, CT and other machines. Therefore, we need to avoid them. This is the case done in the late 1990s. On the CT, in quadrant 4, the alveolar ridge is damaged. Inferior alveolar nerve was repositioned. Long 13mm implants were placed. I did one more case like this. Prosthesis and implant placement were successful, but the patient complained paresthesia. Even though I placed the implants very carefully, the nerve was touched. I don't do like that anymore. In this case, we used to use long implants. Implants were placed lingually from the inferior alveolar nerve without causing paresthesia. Long implants in the past could cause some problems. Today, we have very good X-ray and cone beam CT, digital guide. All those are available, therefore we can place shorter implants. Dr. Park Jong-hyun, would you introduce a similar case? First, let me explain my experience. I experienced the damage to the inferior alveolar nerve once. My understanding about the nerve drastically changed after the experience. So the mistake gives you the lesson. After panorama is taken, I sent this image to all my friends and asked what will happen. They just to be nice, and they said it'll be okay. But the patient came back the next day. The patient said anesthesia on both sides still remains. I couldn't understand what the patient said, and after about 5 days, I took the CT images. The inferior alveolar nerve was touched, and in quadrant 3, the branch was touched, and I could finally understand the situation. 5 days later, I replaced the 7mm implant with a 6mm one, and the patient said the tightening sensation is gone. If I resolve the problem on the day of surgery, the fatal result would not have been created, and prosthesis. 10 months later, the patient came back because I told him that it will get better in 10 months. He said that the lips got better, but the chin, this much, still the problem. It remains the same after 2 years and 5 months. Also, after 4 years, the patient said the skin felt better. However, the problem in the lower anterior remained, and he said he could live with that. He forgave me, therefore I could move on. For the case under discussion, short implants can be used to make the case easier. Dr. Son, Dr. Kim, do you use 5 or 5 millimeter fixtures, placing them above the bone? If there's no bone, that's the only way we can do. Dr. Kim, these days we can use short implants. We used to use long implants, but today we can use short implants. Vertical bone augmentation is not easy. Thus, that's the option we need to choose for the lower anterior region. Regarding the inferior alveolar nerve damage case, if I chose 6 millimeter instead of 7 millimeter, it could have been really nice. Up to 2017, psychologically, I had to use the shortest one, 7 millimeters. But now, I believe 6 millimeter implant would be okay. However, I don't really use 4 or 5 millimeter long implants, because I believe implants need to be totally in bone. This is my junior alumni dentist case. I believe 4 millimeter implant is a good choice here. Regarding the case under discussion, I thought about it. This is a very similar case. 7 millimeter fixture is placed very shallowly. That can cause biological problem later. To prevent that, if we place it deep, it is too close to the inferior alveolar nerve, which is very dangerous. 6 millimeter fixture was placed. Psychologically, when I changed the shortest implant to be 6 millimeters from 7, many cases became easier. The problem here is that the patient waited too long for 2 years until he got eligible to be covered by an insurance. Even with bone graft, I tried to get the initial stability from the residual bone even 1 millimeter from the bone, so I chose 8.5 millimeter fixture and placed it very close to the inferior alveolar nerve. My favorite approach is this. I didn't use a guide there. Initially, the bone is very narrow. Distally, the bone length is short. Ridge splitting is done to secure the width, and additionally, bone graft is done buccally. The problem is here. In order to use this, I use ortho screw as index. In the past, the screw is placed in the bone, and then the measurement on the CT image becomes much more accurate. So I placed the 5 by 6 millimeter implant safely. Panorama after placement. Prostheses were fabricated as much supramarginally as possible, and embrasure was created as big as possible. Ridge splitting is done for number 43 and 44. For number 47, I was worried about the distance to the inferior alveolar nerve, but they all became osseointegrated. I saw you used ortho screw. I believe that is consistent with what Dr. Son said. When people ask about some case, some dentists just sent me CT only without panorama. The measurements taken by the dentist cannot be accurate in terms of when we place an implant. As Dr. Park said, to get accurate path by using the screw, he made pretty accurate measurements. As Dr. Son said before, in general, this applies to sinus graft as well. On the panorama, the height of residual bone shows the lowest height. So when we enter in there, you will find more bone than your measurements. Therefore, people have their own tips to measure accurately the bone height. So let me give you some more tips that I have. Taking X-ray during surgery is very important. Only local dental offices can do that. Some dentists working in a university hospital say that's impossible, but it can be easily done. I use a guide, but I don't trust it 100%. A guide is used when I place an implant near inferior alveolar nerve to get the path and the positioning, but I drill 2 millimeters less than normal and place the implant 2 millimeters less than the depth. Frequently, I take CT or panorama to check. I use 485 kit and move closer to the nerve one step at a time by taking the CT frequently. So this is placed very close to the nerve. It is not a coincidence. It was placed step by step by checking the CT at each step. Without it, it is impossible to place it that close to the nerve. Custom abutment is connected, and now the patient uses temporary for the function. Next week, final delivery is scheduled. I watched one 485 kit presentation in Dental delivered by Dr. Kim Kyung-won. I didn't know one 485 kit was designed with such deep thoughts. The kit can damage the tissue less like casket. That's how I use it. In placing implants near the inferior alveolar nerve, it helps a lot, so I'm very thankful for that. When we utilize a guide, we don't need to trust it wholeheartedly because mistakes can be made due to errors. Even though you use the guide, ultimate responsibility should be borne by a dentist. Even using a guide, I take X-ray at each step. Definitely, there's an advantage in using one guide. We can accurately identify the buccolingual dimension. The panorama, it looks very close to the inferior alveolar nerve. But on CT, as was designed in the first place, we can have some distance from the nerve three-dimensionally. Therefore, using guide is very attractive. I want to say this lastly. I really love to use the tissue level SS fixture. I'm one of those dentists who love it because with less biologic width, the implants can be protected. For two-piece platform matching neck, more biologic width is necessary. For SS, 2.8 millimeter is good enough according to papers. Number 47, SS3, 5 by 6 millimeter fixture was placed. To place it, I took 4 X-rays at various steps. Some people may not agree with me. I use block anesthetic for the inferior alveolar nerve in 99% of the cases, but when it is very close to the nerve, I use infiltration anesthetic. I ask the patient about the feeling in the lower lip, but that is not very important. I learned something from my numbness mistake. This way I can respond very quickly. If I damage the nerve, if paresthesia occurs, I don't have to wait 3 or 4 hours until block anesthetic disappears. So in this case, I only use infiltration anesthetic. Tell the patient to be a little bit patient for a little bit of pain. Here, I would choose 5x5 millimeter implants. That would be a good choice. After final restoration, 2.5 millimeter soft tissue is formed. I think that is good biologic with the 4SS fixture. This is the root apex after treatment is completed. Summary. For a guide fabrication, the case should be thoroughly analyzed. Don't trust the guide 100%. Place 2 mm less than the target depth. Take x-rays several times. Additional drilling should be done with 485 kit. Near the inferior alveolar nerve, only use the infiltration anesthetic, and you need to continuously evaluate the sensation on the lower lip during surgery. You could consider 6 mm fixture as the shortest fixture psychologically instead of 7, or even 5 or 4 mm fixture. Choosing a 6 mm instead of 7 can be your capability. Dr. Park gave us very good summary. If you use a guide and a 485 kit, that's very good. But you said only infiltration anesthetic is used instead of block anesthetic. I don't agree with that. If you use infiltration anesthetic, the patient can feel pain in the lower posterior. It is important to do surgery without making the patient pain. When the planning is very important. Thank you very much for introducing the case. I have a question. The drill that we use, it is a little bit longer than normal. How do you do the drilling? We need to have accurate understanding on drilling. Considering inferior alveolar nerve, the crestal bone should be flat. I am a thorough lover of SS. As soon as I open a flap, I flatten the crestal bone with a denture burr. Then the drill size and the measurements would be in line. If you flatten the crestal bone, you'll be able to apply the drilling concept that we have clinically. Thank you. Dr. Son Young-hee, would you like to talk about the case under discussion? Okay, I have brought a case. Dr. Park gave us very good explanation, so I will not go into details. I don't need to do so. I totally agree with Dr. Park. As someone with a private practice, we don't have a lot of options. Using a short implant is the safest. That's for sure. How to place it? As Dr. Chung said, the accurate depth drilling is not possible with a tapered drilling. There's a tip size, so we tend to drill less than the depth. And we need to consider what Dr. Park said. We don't always do vertical drilling. There's a place where stopper can reach before than others. Therefore, in most cases, we go in there less than the desired depth. As teeth are inclined, we tend to drill at an angle. Therefore, the available bone can increase. We need to determine the drilling length considering that. In my case, if absolutely accurate drilling is required, I use cast drill with a stopper. The cutting edge of the cast drill is flat, so compared to the tapered drill, there is a much lower likelihood of nerve injury. I have brought two cases. The first case, thorough treatment planning and image training in mind is used to manually place the implant. There is a residual root if you think about fixtures that can be used, ultimately we are going to talk about the short implants. I use TS implants in 99% of the cases. I know SS is very good, but in most cases, I use TS implants. It ranges 4.0 to 5.5. Usually, short implants are up to 7 millimeters. However, 7 millimeter length maybe should be classified as normal implants. So I consider 6 millimeters or shorter ones as short implants. The diameter is 5 millimeters. When alveolar process is resolved and only basal bone remains near the nerve, buccolingual width is alright in most cases. So we can use wide fixture, 6 millimeters. It's 6 millimeters, but the drilling depth is 5 or 4 millimeters. So we can think that 654 millimeters can be available. The crestal part of the fixture is not very rough. The surface is smooth. So when it is exposed, there's no problem for soft tissue attachment. And it is placed at a safe place at number 46. After that, in quadrant 3, as you can see, the color is exposed. This is 5 by 6 millimeter, and the color is 1 millimeter. And the drilling depth is 5 millimeters. It used to be TS3-506 ES1. Now the name is changed. It's a 5 millimeter, and the length is a 6 millimeter fixture. If you look at the CT, it is quite distant from the nerve. Prosthesis is completed. Number 47, I persuaded a patient to go without it. And the number 17 was not good, but the patient insisted on having it, so I had to place it there. But fixture is at number 6. It is very difficult to drill if there is a prosthesis, so it is removed and the healing abutment was connected. With a minimal flap, it was placed. 5 by 6 millimeter fixture is placed. So people say it should be placed a little bit lingually, and I'm so accustomed to placing it quite lingually. There are dentists who are concerned that you can break the lingual cortical plate. It requires real hard pressure. If you don't apply too much pressure there deliberately, the lingual plate will not break. So if you can do very good drilling, you can place the implant manually. If you have a lot of experience of that, if we look at the CT image very carefully, and still you will find the actual situation can be different from the CT image. If you're concerned about that, you can use the guide. I don't trust it 100%, but I trust it more than myself. Patient wanted an implant at quadrant 3. On the CT, the problem is the basal bone is very much resorbed, and the buccal bone as well. Length of the basal bone is too short, especially at number 37. That's a concern. So guided surgery was done. The buccal side requires GBR. The implant will be placed not so deep, and GBR will be done there. It is a posterior region, so an open hole guide is used, as she had a very limited mouth opening. They were placed deep but luckily the color is exposed. 6 millimeter GBR is done. If you look at here, post-op CT, you can see the implant was placed very safely. If you're not sure, guided surgery is the most safest way. So prosthesis is done. After prosthesis done, CT was taken. So if there is a vertical limitations due to anatomical structure, we need to have a very accurate diagnosis and drilling. And it is essential to accurately position vertically the fixture. If you use the guided surgery, you can place the implants more safely. So that is what I recommend. We have talked about how to deal with the cases where implants need to be placed very close to the inferior alveolar nerve. Let's go back to the case under discussion. Based on what we have discussed, would you give us the closing remarks? In my case, in the past, I used to place long implants, but these days we don't do such reckless surgeries. As Dr. Park Jung-hyun said, Osstem's 485 kit is designed without the inferior wide dimension, just like the flat tip of cast drill. So if we drill up to the laser mark, we can measure accurate depth and we can give accurate diagnosis, and we can use short implants. As Dr. Son said, we can use guided surgery to be safe. Compared to the cases introduced by Dr. Park and Dr. Son, this case under discussion is much safer. If you are not confident, I believe you need to use the guided surgery. In my view, this patient, if you decide on using short implants, it will be very safe, and you can aggressively choose that path to avoid the damage to the nerve. Dr. Park Jong-hyun, Dr. Son and Dr. Kim gave us very good summary. I don't have anything to add, but I have a question to Dr. Son. Dr. Son uses the concept very similar to mine. I selected a TS 5mm long implant and placed it, and I found the distance to the nerve is quite long enough. Is there a difference between placing 5mm implant deeper and placing 6mm fixture with roughened surface up to the top? If you ask my personal opinion, I don't think there is a difference between them. It is widely known that the diameter of an implant has more influence in the survival of an implant. If it is a wide diameter implant, whether it is 5 or 6mm long, doesn't make a difference. So I choose 5mm implant, but it is just a tried-in. As Dr. Son said, I find more bone in there, so in the future I will leave 5mm implant there instead of replacing it with 6mm. On behalf of our audience, let me ask this question. What do you think of placing an implant after vertical GBR? I believe, like the case under discussion, number 7 is the most posterior tooth. Vertical augmentation there is not easy. In the past, we used a block bone, but it was rather challenging. In this case, the most posterior tooth, when GBR is done, it looks okay at the beginning, but problems occur later, so I would not choose that. If there is a number 5 and number 7 teeth and number 6 has concave ridge, then vertical augmentation can be done even using a block bone. But number 7 distal case, I would go for using a short implant. Doing vertical augmentation can be an option, but in this case, if block bone should be used, to be honest, the vertical augmentation I have done looks good at the beginning, but under function, in many cases, they are resorbed quite seriously, so it has poor prognosis, and placing a short implant has better prognosis. As Dr. Kim Kyung-won said. Thank you. In this case discussion, we talked about a case of placing an implant very close to the inferior alveolar nerve. I would like to thank the dentist who sent us the case and the audience. This concludes the case discussion today. I would like to thank Dr. Park Jong-hyun, Dr. Son Young-hee, and Dr. Kim Kyung-won. I am Dr. Jung Young-eun, and I'll come back next time. Thank you very much.
고맙습니다.